So my name's Howard Bachner, and I'm here from JAMA. I started about 2 or 2.5 years ago. And I'll make some brief comments about the journal in a bit, but I thought we'd start by letting actually each of the panelists introduce themselves, because I've found that they actually do a much better job introducing themselves than my reading their bios to you, which you're more than capable of doing. So, Atul, why don't we start with you?
Sure, I'm Atul Grover. I'm a general internist and health services researcher. I'm the Chief Public Policy Officer at the Association of American Medical Colleges.
Lois?
Good morning. I'm Lois Margaret Nora. I am a medical educator and president of the American Board of Medical Specialties, an organization that's focused on career-long learning and assessment of physicians.
Nida?
Good morning. My name is Nida Degasis. I am the national president of the American Medical Student Association, or AMSA. AMSA is the largest independent student-run and student-governed organization, and so I represent about 35,000 physicians in training, and I'm a recent graduate of medical school.
Thanks. So we'll get to the questions in a second. Just a couple very brief comments about JAMA. So we touch between 500,000 and 800,000 physicians each week with our content. And those are physicians around the world. We have a print circulation of 325,000. Our digital fingerprint and alerts go out to about 400,000 people. We don't know how many are duplicates. And then through social media, we now touch about 200,000 people. So worldwide, we think we touch between 500,000 and 700,000 individuals. We've also learned that we need to be an agnostic communicator, and that's critically important. I like reading a journal in print, but my children would never read a journal in print. They would think I'd lost my mind if I asked them to read a journal in print. Our viewpoints are now audio taped, and we do 3 or 4 viewpoints a week. And when we introduced them about 3 months ago as an audio file, the uptake has now reached about 10,000 a week. So we know that people also like listening to our content. Well before I came, we've produced author report videos for the public consumption, and we average about 15 or 16 million viewers around the world each week with the author report video. So we know our reach and our fingerprint is very deep, both in the United States and around the world. I often say I have about 400,000 or 500,000 bosses, and I hear from them quite regularly through email about what our content should be or what our content shouldn't be. Or changes that we've made in the journal since I've arrived. I'll gladly field any questions later about the change in the cover, okay? Because I have heard regularly about the change in the cover. It's usually very age-related, but I'm more than willing to field questions about the cover. Part of our contact has been to try to help physicians understand a bit more about healthcare reform, but I suspect there's none of us who would like to be on a podium and answer 20 questions about healthcare reform. It's unbelievably complicated, okay? Phil Fontana and I, Phil's the executive editor, we get 1,500 viewpoints a year. We publish about 150, but it affords us just this extraordinary landscape of American medicine. And healthcare reform is darn confusing. And we can get a viewpoint that says one thing on Monday and a viewpoint that says exactly the opposite on Tuesday, and they both claim they're factual. So I think part of the struggle is that it's really very, very confusing. But we have tried to create new networks and new partnerships. Drew Altman has really been wonderful. We have this wonderful partnership with the Kaiser Family Foundation, which is called Visualizing Health Policy. And they produce for us something that's a kind of visual depiction of health policy issues. And then obviously we have our opinion pieces, and then which we reproduce as both videos and audios. So I'll stop there. I just wanted to give you a bit of the landscape as I view it as a journal editor. So I'm going to sit, but why don't we start with the first question to the panelists. firstly, do you agree that clinicians are confused about payment and delivery reform? So that would be one. I think I know what the answer will be. And more importantly, what's the appropriate role for clinicians? But why don't we start with the first question to the panelists. Are clinicians confused about payment and delivery reform?
So here's the question: who's not confused about payment and delivery reform? I think it is an area of tremendous change, and that's part of what makes this initiative so exciting, because I think physicians are very interested in knowing, very interested in being aware of relevant information to the care they provide their patients. And so new opportunities for them to have relevant information just in time and be aware of changes that are happening as they happen, I think is phenomenal.
I would say I'm a physician. I do health policy for a living, and I'm confused. I don't understand every aspect of what's happening. I can't predict on a day-to-day basis or year-to-year what the system's going to look like, and I think that's very difficult, in particular for people who are learners, as we all are, but who are professional learners, to say, what is this going to look like 7 or 8 years out when you're done with your commitment to your education and we set you loose on the world to practice independently? Even my members that I work for, the 141 medical schools and 300 major teaching hospitals and health systems, we deliver about 20% of all the clinical care in the country. We have, at any given time, 300,000 physicians in training or medical students in our midst, and among people who will tell you they are the smartest people in the world. And for them...
They will tell you that.
They will tell you that. Sometimes they're right. And for them, this is all a huge learning process as well. And I think it's just a struggle to not only take up all the great information that comes out from JAMA or other sources of medical information and learning we have every day, and then to cram in all this additional knowledge. And one of my accreditation colleagues once said to me, the medical school curriculum is the only organism without an excretory function. And I think that's the other challenge that we have.
And I think that actually makes it a very good point in that I don't think medical students or physicians in training are confused. I think the issue is the general student is not exposed to enough information to even be confused at this point. The medical school curricula is not, this is not a formal part of most medical education. And so if they were exposed to the different types of reforms or the different types of changes possible, then I think we'd be confused as well.
Yeah, and I think one of the challenges there is context. And so whether we've been struggling with teaching quality improvement, patient safety for the last 20 years. And the question is, when is it the right time to infuse it into the curriculum? I would argue that you have to do it everywhere from your anatomy and pathology lectures all the way through your clinical training. But when does it really stick? And I think putting this in the right context is a real challenge. Now, I happen to teach health policy to undergrads at Johns Hopkins, where public health is the second largest major for undergrads. Half of those folks in my class of 180 that I taught earlier this week are going to apply to medical school. I think that's actually a great place to start. And with the changes we're making to the MCAT that'll be implemented next year in 2015, requiring more social and behavioral health, requiring more of these prerequisite courses, I think giving folks a grounding before they even enter clinical training is going to be to their advantage.
I couldn't agree more.
Just a follow-up question about that. To me, that may be appropriate, but it really doesn't solve the problem. There's 900,000 physicians in practice, 20,000 graduate a year. It would be 20 years until we had enough people in practice to educate the public. So I certainly wouldn't dismiss the 20,000 medical students. There's about 80,000 residents and fellows. It's about 100,000 physicians in training if you include medical students. But you have 500,000 or 600,000 docs in practice. So
I think that's one of the reasons why I'm on this program. And I completely agree with my colleagues that enculturating this and beginning this right from the beginning of medical school and even pre-med is critically important. I'm a neurologist. I finished my residency in 1987. Think about what changes we have seen in medicine. Think about what changes we've had in healthcare delivery over that period of time. It was during my residency that we first recognized there was a disease called AIDS and HIV. Think about the social changes in construct, Very much physician is captain of the ship, where today we recognize that the interprofessional team, with the physician taking leadership where appropriate, but also being a follower when appropriate, is also critical. And that's where programs like maintenance of certification that the American Board of Medical Specialties and its 24-member boards now have in place. There are close to 800 board-certified physicians in the United States, and now close to 500,000 of those physicians are involved in a career-long learning and assessment process called maintenance of certification. It has 4 parts. It is built on the 6 competencies, one of which is systems-based practice. And those 4 parts help physicians across their career learn new things, not just in the basic and clinical science that they are practicing, but potentially in things like delivery reform and payment mechanisms.
And I think those core competencies, and we owe a great deal of debt to the graduate medical education folks, the ACGME, for really fleshing this out and having some measurable milestones. I believe that's now expanding to both UME, or med school, as well as to CME. And I would argue that within our academic institutions, we have 1.9 million people that are employed. And in fact, we have 120,000 faculty physicians in our practice plans. We have 120,000 residents and fellows in training, and 86,000 medical students that we touch every day. I think it's a pretty good core of folks to begin with. Yes, we can train up 26,000 perfect clinicians every day that finish their residency or fellowship and send them out in the world. They will have the reality of the current system beaten out of them. I believe that the academic centers actually can provide a nidus, because we do CME, we do GME, and we do UME, and increasingly pre-med.
And I think that the assumption that we're making that only those in current practice can make change is the wrong assumption to make. I think what has been demonstrated, I think, by AMSA itself, that student-led activism and student-led change, we're looking at a huge pool of future, not just the future of medicine, but also currently individuals who have different ideas and different thought processes on how to reform the current system. And so I think to ignore them because they're not currently practicing is doing a major disservice to healthcare reform.
I'd also say, as a former medical school dean, the opportunity for students to actually be a focus of learning and take new information out to physicians where they're at. I will tell you, Commonwealth Medical College, which is one of the new community-based medical schools in Pennsylvania, their physicians talk about how they've been introduced to technology because initially they thought the student was kind of being rude and looking at their phone. And then they realized that the student was finding the answer to the question that had just been asked on rounds.
So in a month, I'm going to sit on a different panel that's going to be focused on education and genetics. And I'm going to hear the same thing, that it needs to be added to everyone's education. It needs to be really part of core competencies. And in the emails and letters that I get, a lot of physicians are saying no more. All of you policy wanks keep pushing back to us more and more work. I'm trying to make a living. I work really hard. I have to understand all the movement of my insurers and all of the changes that I'm grappling with. We have a paper coming out. It's a very detailed paper in genetics. I believe it's in English. I am not certain it's in English. I'm requesting that there be a box of terminology. And, you know, on one hand, people laugh, but on the other hand, whenever we add those things, I hear, thanks for telling us, giving us landmarks about what we're reading. So I recognize the importance of this, but it competes with many, many other issues. And I haven't heard a lot of wisdom about how to reconcile the competition. We have reduced work hours, not longer work hours. I've heard from my surgical colleagues it's really great if they know about systems, but would you like them to be technologically proficient when they go into the operating room? Right. These are real tensions, and we tend to avoid these tensions. So I'd like you to comment about that. I'm not certain that in offices that you really want the physician educating patients about medical reform. I'm not sure they're the right person. Right. I know we're committed to thinking they're the right people. I'm not entirely sure they are the right people. So I'd like you to just comment on those ideas.
partly I would say, so what are the core competencies that every physician should have about these topics? And then what are the opportunities for physicians who wish to take it a step further and become more engaged, and make sure that we have those opportunities? You mentioned the very real issues that many physicians have about, they speak about maintenance of certification. They want to learn. They're not worried about being assessed, but they want it to be relevant to their care. They want it to be available to them. So some of our boards, for example, are introducing just-in-time opportunities where they can get credit for medical knowledge that they're accessing at the bedside to immediately care for that patient. So I think the issues that you're talking about are very relevant.
I think one of the challenges, and this is a challenge for our institutions of higher learning, how do you move the people who are teaching the next generation into a space where they're constantly asking these questions? I don't think you can cram or count the hours in a curriculum about nutrition or genetics or LGBT issues or health policy. I think it has to become part of the conversation, so that as we're learning in pathology, this is what an abnormal pap smear looks like, is somebody asking the question, what happens if that lab result doesn't get back to the patient? What happens if there's a delay in diagnosis? I think all that is going to take a long time to work out. I believe just as we had a need for chief medical officers to translate the suits to the frontline clinicians, we need people like McClellan and Darshak and Nancy Nielsen and other friends in this room who are going to translate broader policy issues to the field of medicine, whether that's in MDs or nursing or public health or social work or pharmacy. We need to train up that cadre to create a group of champions the same way we have in patient safety.
And I think that while trying to add more to the formal curriculum, which is very difficult, because at what cost, what goes? Do you get rid of anatomy? Of course not. No one would suggest that for physicians in training, to get rid of other core, get rid of anatomy.
But it's changed.
But it has changed, and I think that there are ways to integrate this throughout the medical curriculum. And then there are opportunities for organizations like AMSA to provide complementary educational opportunities, experiences, and education for medical students and for physicians in training. For example, we have already done this specifically on the health care reform front. We provide lots of opportunities for students to get involved in terms of webinar trainings, learning specific skills, advocacy skills, which you do not learn in medical school, how to lobby, how to talk to your congressperson, how to take things that matter to you and that matter to your community and make those things happen. And I think this is a really very good opportunity for organizations like AMSA and other professional organizations to try to fill those gaps, those medical education gaps.
I think we started with the assumption that clinicians have limited knowledge about healthcare reform. We all struggle with it. I think there's general agreement about that. And then we sort of leap to the assumption that somehow clinicians need to learn more and then communicate or talk with patients about it. I'd like to just return, can you envision other models of trying to educate the public about healthcare reform that don't involve the clinician or minimize clinician time in that discussion? I appreciate that at certain times it will be necessary, but you know, we're beginning to utilize physician extenders
Absolutely.
in many different areas. So in the province of a 60 or 70 hour work week, is this what you want the clinician spending 10 or 12 hours a day on?
You know, I think leadership is incredibly important. And physicians are oftentimes the leader within or a leader within their practice environment. But one of the things that the MOC work on improvement in medical practice has demonstrated, that physicians relish the opportunity to use interprofessional teams most effectively and are gaining real benefit from things that do that relative to medical care. And I would suggest this may be, we know that patient advocates, that patient educators, we know that attention to what is in the waiting room and the level, the grade level that it is framed at are all very important ways that physicians can powerfully help educate the community of patients that they care for, while actually oftentimes having people who may do it more effectively than the individual physician participate.
And I think that's I would agree with Lois's comments, and certainly anybody that's going through medical education now, I would hope, and certainly when I finished my residency a little bit after Lois, had a clinical pharmacist on the team and social worker and nurse caseworker. And we're all friends. And, but I do think the issue is, and maybe our journalists can talk about this during their panel, is who's the trusted source, right? You need a trusted source for that information and one that actually is accurate. And unfortunately, those two things don't often go together, whether that's in medicine or in journalism. So how do we create a cadre of trusted sources, trusted information, and maybe it is that we have the literacy and culturally appropriate materials in the waiting room of our institutions. I know that our centers have now been training up just legions of these navigators and counselors, and so we've managed to do it through others, not through the physicians. I wish we'd educated some of the physicians and nurses a little bit more in the process, but I think you use whoever you can get, but it has to be a trusted source.
Yeah, absolutely. And I think that this brings it to the point of, obviously, maybe not most cost effective to have physicians spending 10, 12 hours a week. And I would not argue that. But I do think that this is an opportunity not only for physicians to lead, but for physicians to train others, not even necessarily healthcare extenders. Talking about those pre-medical students, that is a huge opportunity for students to get engaged in the healthcare reform process and talking about these things with their communities, in offices, a wonderful opportunity. Most likely they'll volunteer. You don't even have to pay those individuals, but are they a trusted source? And I think that we're thinking about this very traditionally in terms of how do we talk to our patients. We live in a world today where social media is huge. People get their news sources from Jon Stewart and from Colbert Report and from other sources other than just their physician. And so we have to think about ways of engaging. And I know we have a panel later on this morning specifically talking about social media, the appropriate use of social media, how to really use that to talk to patients, talk to the communities. But I think it really does come down to community organizing. Who in the community is a trusted source? I think we saw a lot with that with the enrollment rollout for the ACA this year. And I think that's really what it's going to come down to, is looking at who in the community can help provide this educational source.
I think one of the challenges with social media, which I'm fairly new to, is that it's a trusted source of people who you select to listen to. And so maybe it was Ted who tweeted out something the other day, or one of his colleagues that said, it turns out all the anti-vaccination chat was going on Facebook, all the pro-vaccination chat was going on Twitter. And how do we navigate that world in a land?
I'll comment on that in a second. Nancy?
One of the things that I'd like to point out that I think is critically important for practicing physicians to be engaged in. In medical education, we talk about the formal curriculum and the hidden curriculum. And the hidden curriculum is the environment in which the student or others walk into after learning about these things. And so real attention for practicing physicians and helping them to understand the important role they play on the quality part of the value education, on recognizing that being involved in these conversations is important to their patient care and legitimate activity, because I want to make sure that when medical students are working with a physician, that physician is underscoring the importance of awareness of what is happening in payment reform, patient care, systems-based practice, and the medical student isn't facing that disconnect.
Yeah. I just wanted to return to your comment. So journals have generally been static communication devices. We do know that users are much more in control of how they interact, but they're not very dynamic. And we're just beginning to try to understand how to harness conversation in the social media spaces, Twitter and Facebook specifically. We're looking at technologies that can drive a conversation between the journal and the people who access us on Twitter and Facebook. And we think in the next year we'll be able to curate comments to create a discussion that actually is two-way, and it will be curated and orchestrated, because we don't want a free-for-all. Right. But I think what journals haven't done very well is we don't want to invent technology, but we need to utilize emerging technologies better to create conversations, and we haven't done a very good job with that. So it was interesting to hear your comment. Darshak, we have about 15 minutes, and we can keep talking, but it's a small
Clearly
group.
we can keep talking.
So I didn't know if you had anticipated that I would stop and we'd just see if people have comments or questions from the audience.
Thanks for asking.
It's really small. People can just shout it out or speak up.
So sorry, I should have clarified that, yes, we would like to engage the audience, so if you can take some questions, that'd be great. And then I just point out also, we are live.
I assume that's
chat,
okay.
So you can also submit a question if you like through Twitter as well, using the hashtag Merkin14.
Social media work.
So we have somebody who's going to.
I don't know everyone, so I apologize.
I'm not for the medical profession. What I hear you saying is having the doctors, should the doctors be explaining or talking, discussing healthcare reform with patients? And I guess I want to know what exactly you're saying. My cardiologist, my general practitioner should be sitting there explaining what's wrong and right about the Affordable Care Act? Is that the kind of things? I don't know what you mean. What are the doctor going to spend his time about health care reform? And let me just say one other thing, which I think is kind of interesting. Over the last 4 or 5 years, since the passage of the Health Care Reform Act, I have been astounded by going to my physicians, who are outstanding physicians, substantively, and I'm happier they spend their time on that. They changed the heart valve correctly, that's what counts. And the people around the doctor's office and medical students asking, how will the Affordable Care Act affect you? And boy, if eyes could glaze over, no knowledge, this is over a period of years, no knowledge, no interest, and it didn't sound like anything that really would affect them. And I'm talking outstanding institutions, and I'm wondering why those questions weren't asked. And really, again, back to the essential question, what are you asking a doctor to do with politics or healthcare reform?
I think the answer is that, and one of the challenges is that for most people right now, today, it doesn't change that much. And so if you're already insured, the 85% of people that were already accessing healthcare, and we can talk about what's going to happen in delivering payment reform 5, 10 years from now, depending on what that glide path is. But for right now, this was a way to expand insurance to people who couldn't get insurance and who needed healthcare. But I would say that what it can do is if you are a patient who is 55 or 60 and running a small business, to say, one of the things it does is you don't have to worry about leaving an employer if you want to change to another business. This is going to be easier for you. If these are things that make a difference in your daily life in terms of how you make decisions, you should know about them. We should be able to explain these things to you. Now, what it does to or didn't do to the SGR, or what bundled payments is going to do, I don't think we need to get into that with patients. But there are some basic things we ought to know.
With all due respect, if I could just follow up, there are a lot of media sources that would say considerably more than what you just said about the Affordable Care Act. They emphasize that there are millions of people that have lost their insurance policies, and that's certainly multiplied because a lot of them are family sort of situations. And I just I like you, but you're the one to emphasize trusted sources.
Right.
And my antenna went up when the description of what the country is going through right now was just, this means a lot more people are going to get health insurance and it's a great deal.
For some people that didn't have a certain standard of insurance, it didn't work out so well. And let's talk about how we move forward as a patient and make sure you get the care you need.
So not to debate the pros and the cons of the ACA or what have you, but I do think what you're asking specifically is what would you spend time talking to patients about? And I think it depends on what practice you're in. So for example, in emergency medicine, which hopefully is what I will match in on March 21st, that I have a very specific patient population that now potentially, depending on their income sources, I can talk to them about enrolling in Medicaid or making sure that they can get covered or helping them navigate the current system. And that's something that I should be taking a few minutes to talk to, even in a very short emergency department visit. And not just me, but the team of providers, right? So we have the social workers, we have really amazing secretaries, we have nurses. I mean, there's a huge team that this is a huge opportunity to help that individual or that family. And so I do think it's appropriate to take time to discuss that. Or, for example, in a primary care office to talk about, well, now you can get preventive healthcare services. This is what's available to you. I think that's, again, very important. I think it's very specific to what practice you're in. But I do think it's important to speak with patients about this. Absolutely.
I guess
Go ahead.
a couple of comments.
There's-
Couple of quick comments and question. Having taught medicine for 22 years, there is a lot. Now, I did have a professor, subsequently a chair at a major medical school, who did say that he thought an internist only needed to know where the heart and the liver were. So just in terms of your anatomy question. You know, many of the patients that I've encountered over time, when they come to see the physician, are much more concerned with what's wrong with me, what are you going to do about it, and what's my prognosis. So I'm just not sure at all that an office visit is the time to deal with that. I mean, it may come up in the context of how am I going to pay for this, but I agree that that is usually not the role of the physician to deal with. The other thing I'd just note very quickly is that another trusted source of information, very underutilized by our profession, are ministers and pastors. And to the degree that they care about their flock, I mean, many, for example, have gone on an anti-tobacco campaign or you know, an anti-obesity, let's exercise more. So I think there are other groups, and we do need to think much more creatively about this.
I agree, because I think what we are most focused on is, for that physician, what do they need to know to best negotiate the system on behalf of their patients? And more, working with communities and community agencies is an important part of it.
Go ahead, ma'am. No.
Yeah. Waiting for the microphone.
Oh, microphone? I don't know if it's working.
I'm Dr. Caroline Poplin. I'm a primary care physician. I'm 67, and I'm going to have to take a 6-hour, 360 multiple choice exam. Now, you're not 67 yet, but you'll see when you get there that it's not as easy as it used to be. What concerns me is this is a panel about delivering information about delivery and payment reform to physicians. What is distressing as a physician is that why aren't we ever asked what we think about what we think delivery reform should look like and what we think payment reform should look like. In fact, and what we think recertification should look like. I recertified in 2004. I was a physician at Bethesda Naval Hospital. And it had absolutely nothing to do with my practice. It just took a lot of time and a lot of money and a lot of frustration. I don't think we should be involved in payment and delivery reform. I think we should be leading payment reform. And in fact, we're never asked. We're just told in JAMA and what we're supposed to do. The assumption is that doctors are lazy, stupid. They will not keep up with their profession, with the scientific developments, unless they have to pass a test.
Do anyone want to comment?
Sure. Could I thank you for your comment while disagreeing hugely with it? I think doctors are actually very altruistic people who are passionate about lifelong learning and want to do best for their patients, and that includes learning. I believe that maintenance of certification, which is ultimately a voluntary activity, is rigorous. It is difficult. Believe me, I knew what Howard was coming from earlier. I'm studying for my MOC exam, and I am finding out that there are new terms in genetics I don't recognize. Well, maybe I should if I call myself a neurologist. So let me thank you. I think we fundamentally agree that it has to be relevant and physicians should be involved. I'm delighted that over 1,200 physicians took the time at meetings and online to give us feedback about the MOC standards recently.
And I think your question was specifically on payment reform and delivery and if physicians are being asked. Now, again, being from AMSA, I'm not entirely certain of all the professional societies, but I do know the Society of General Internal Medicine did put together the Commission on Payment Reform, which my understanding was put together by a small but yet still a group of physicians that did provide their recommendations. So I don't know if other organizations do something similar.
Most of the physician voice is relegated to professional physician organizations, and the question is, are they representing the views that you would like them to represent to policymakers?
The American College of Physicians, no, they represent, I went around with this in writing with Robert Doherty. They represent the leadership. They do not represent the membership. They were not designed to be a lobbying organization. Robert Doherty said, well, what do you expect me to do, take a survey?
I appreciate your comments, but if we can move on, just right here, please. Just a comment. It's been an interesting discussion about what docs should do with patients, but I would say for me, medicine starts at the individual encounter between a provider, often a physician, but not always a physician, and a patient. And I think the one major change in the last 20 or 30 years is who sets the agenda in that encounter. And I think we need to hold on that should still be patient-driven.
Yes.
It doesn't need to be exclusively by the patient, but I was struck by the comment that when I go to see my doctor, you know, the insurance form may be important at some point, but I just want to get well, or I want to know about my health. And so I do think even in the midst of great change, we need to be very careful about not replacing the intimacy of that relationship with anything else, because that's who we represent to patients, the value. Jordy Cohen was in my office the other day, and you know, he's at the Gold Foundation now, and he really is concerned about that sense of humanism in medicine. And I think if we try to listen hard in the encounters about what patients would want from us, it's generally a good starting point. It may not be the only conversation, but it's generally a good starting point. You had a comment? No, go ahead, right, this gentleman right here. I'm sorry, I'm watching when hands go up. Go ahead.
Thank you. Mike Miller, I'm a physician in residence. Thank you. Mike Miller, I'm the physician in residence at the National Governors Association. I want to get back to some of the comments that were made earlier about challenges of educating physicians about what's going on in health reform, both the ACA and just general market changes. I mean, what we see is, you know, vast differences across the country, and I think approaching physicians as a monolithic singularity is not the right way to go, because a physician who's in a Pioneer ACO kind of integrated health system is very different than a physician in a rural practice, just like a psychiatrist as a brain doctor is very different than a neurosurgeon as a brain doctor. Very different skill sets, very different knowledge bases they need to know. You know, we work with different medical groups in different states and help them try and understand what's going on, but the way we approach it is very different depending on where they're starting from. So can maybe the panelists talk about how to personalize, individualize the education delivered to physicians in training or in practice that meets their individual needs to learn what they need to know, the level they need to be brought up to.
It all gets back to this idea of education being a continuum and not just being time and seat. And you have to get, for my pioneers, they're learning from each other, right? They're figuring out incrementally what the next step is. But my shared savings programs, people are trying to learn from the pioneers, trying to learn from each other. It's very different from what I'm giving that rural, solo practitioner. And you have to be able to get people through that continuum and have materials that get them the whole way along so that everybody's learning, everybody's moving forward.
One of the new standards emphasizes the importance of relevance and meeting the physician where the physician is at in learning and assessment. And I think that we're we're seeing a number of examples. I know today we're talking about MOOCs, and I'm particularly excited about MOOCs because, frankly, I think Twitter and the like, for a certain generation in medicine right now, it's the bee's knees and it's what's going to happen. MOOCs in some ways feel particularly good to me because I see a number of people, even in older generations, being able to access information in a new way, but not in such a dramatically new way. And I think so. I think today's focus on social media at all aspects of it, and including MOOCs within that, is actually very powerful to getting to people where they're at and helping them be the best there, and also being lifelong learners so they can negotiate as time goes on.
Your comment, though, made me think of when my first rotation as a second-year pediatric resident was in the neonatal intensive care unit. I just didn't want to kill anyone. You know, I didn't really care about health policy, okay? My goal was to make sure I could intubate the baby and do the right ventilatory settings. And so
And that is exactly what we would have you doing.
That's right. So I think that obviously the key is to match a learner's needs to the time and place of their life.
And I think a really good example of that actually has been demonstrated to do very well. The Institute for Healthcare Improvement's Open School online modules, similar to MOOCs, really trained physicians in training and clinicians, actually. It's interprofessional, anyone can take it, either med students, pre-medical students, residents, physicians practicing you start at your own level, you go at your own pace, and that way you could learn patient safety topics that weren't necessarily already put into your curriculum. So that's another form that it proves that it was very successful.
We just got our ice skating score of 1, which, is that our score, or does that mean we only have 1 minute? 1 minute. I thought we did better than a 1. I don't know, a 7 or an 8.
Right.
Maybe not a 10, but maybe a 7 or 8. I think we have time for one last comment or question.
Hi, my name is Jen DeAngelis. I'm a healthcare advisor to Senator Sheldon Whitehouse. Payment and delivery system reform is his top healthcare priority. And speaking to the doctor's comments about who's asking what physicians want, my boss is very interested in hearing from physicians. We hold several events in Rhode Island, but the reality of what I've seen is that whenever we hold these discussions, and he's very interested in, what does delivery system reform mean in Rhode Island? What can we do to support physicians in building this community of improved care? But it's always the usual suspects. We have our head of our one ACO. We have the CEO of our 2 healthcare systems. We have the health insurance commissioner. My question is, and this is for the panel and for the audience, what can we be doing to engage, the mom and pop shops, physicians? Right now we're talking to the 1% of people who care. What can we do, employing social media or otherwise, to really get the message out that not only does my boss care, but we want to hear from physicians? Thank you.
Brief comments, and then we'll finish.
Thank you. I think you're talking about a very important issue that we're all concerned about in terms of getting.
We don't know how to engage people yet, and I don't know if it's Twitter or Facebook or whatever, but.
Yeah, I absolutely agree. It's a challenge, and you're right. You're talking to the same people over and over. How will you get a diverse representation of physicians? I think it's challenging. If we knew how to do it, they'd all be talking to your boss. So
there are physician chat rooms, and people harness the information from those physician chat rooms for different reasons. And then obviously there's the issue of who enters a physician chat room. But that said, I think we know in surveys response rates have plummeted over the previous decade. So survey isn't going to be a very successful tool. So I think it's going to be somewhere in the world of social media. But physician chat rooms certainly give you a complexion of American physicians. But there's probably other techniques. I think we need to stop. I apologize. I didn't get to all the comments or questions. And I just want to thank our panelists and remind them to take off their microphones.
thank you.